Hello, this is Dr. Purcell, and we are going to go over Fluid and Electrolytes, Chapter 29 in our ninth edition of Lily. I say ninth edition, I hope that I'm saying the right edition. There's so many editions, it's so hard to keep track of all these books. But if you're in Chapter 29 and it's on page 464, then we are all in the right place. This, if you notice in your table of contents, fluids and electrolytes, this chapter comes under drugs that affect cardiovascular and renal system. So this needs to tell you a big thing right now. The effects of fluid and electrolytes are going to, remember all those things we talk about, adverse effects, indications, they're all going to have to do with renal and cardiac. So as we come through, let's see how that goes. We're not covering everything in here, but we're covering a few things in here. Let's come down. There are some key terms that you might want to be familiar with. Hopefully these are familiar to you from pathophys, but things like extracellular fluid, homeostasis, hyperkalemia, hypernatremia, hypokalemia, hyponatremia, interstitial fluid, intracellular fluid, and intravascular fluid are all things you really need to be familiar with. Isotonic, hypotonic, hypertonic as well. So that was just a quick reminder to you to know those terms. I won't really be defining them as we go through here. Make my screen a little bit easier to read here. All right, we start with the overview of the chapter. And fluid and electrolytes. The management of fluid and electrolytes is one of the cornerstones of patient care. This is something you'll manage pretty much in every single patient you encounter. In some form or another, you will be managing this. So it's very important for you to really understand this whole, the nuances of this whole area. As it goes on to say, most disease processes, most tissue injuries, and most surgical procedures greatly influence the physiologic status of fluid and electrolytes in the body. That's why it is one of the cornerstones of patient care. Just a quick reminder, and I'm not going to review the patho very much, but if you think about the fact that 60% of the adult human body weight is composed of water. That is why when we weigh a patient every day at the same time with the same scale, it's a very, very accurate indicator of fluid volume and whether or not the patient is holding too much fluid or not enough fluid. So what that's referred to is total body water. That 60% of the human body, the adult human body, is water. Well, that's the total body water. The percent of body water is higher in infants and lower in older adults. So here's some of our age considerations, lifespan considerations here. So in our infants, they have more water. Well, kind of think about where they just came from. Inside the womb, inside an amniotic sac. And in order for there to be like a symbiosis, homeostasis between the fetus and the amniotic sac, the fluid in there, they had to have an equal gradient, right? Otherwise, the amniotic sac would be pulling fluid out of the neonate or the fetus, or the fetus would be pulling fluid from the amniotic sac. But that would not be a favorable environment. So they're equal so that the fetus is able to be suspended in that ball of fluid. That is why when they're born, they have a higher water content than they will later on in their development. But that is something to keep in mind when we talk about how these drugs might be used in that population. Now, as we know, some of the things that happen with older adults and with aging, they'll have less composition of water in their body. So both of those populations are very sensitive to imbalances in their fluid status and electrolyte changes than the normal adult. So you'll remember that total body water, the TBW, is divided between two main compartments: intracellular, what's in the cell; extracellular, what's outside of the cell. And that's where you see electrolytes and stuff move back and forth. And then that extracellular fluid is further divided into the interstitial fluid and intravascular fluid. I'm going to come on down here. I have highlighted a few things that are reminders for you as you review the pathophys on fluid. Let's see if there's anything in here. Okay, coming down to this blue area, the goal of fluid and electrolyte balance. So here's where we begin on applying pharmacology in here. So the goal to getting a balance is to maintain homeostasis. And that's when fluid intake is equal to fluid output. That's why we measure intake and output on our patients. In the hospitalized patient, measuring all sources of intake and output is extremely important to measure and document. And let's not forget, measurable loss comes from fistulas, drains, GI suction, anything where fluid is coming out, not just urine. A sudden change in weight in a patient is meaning up or down is a strong indicator of fluid balance. Let's come on down. Most of the rest is a review of your pathophys. So here are different types of dehydration that can occur in our patients. Hypertonic dehydration, hypotonic, or isotonic. When we have hypertonic dehydration, think about a patient with a fever and they're perspiring. And you know, a fever raises the core body temperature to make a hostile environment for bacteria or viruses, hoping to kill them. But what happens when it's really hot? When it's really hot outside, what do? We sweat, right? We lose fluid, we lose through perspiration, and we need water. Well, that's the same thing here. So there's a water loss, which is greater than sodium loss. So when you have a lot of urine output, there's a lot of sodium that goes with that. But perspiration is coming through the skin. So you're losing more water than you are sodium. That's a hypertonic type of dehydration. A hypotonic dehydration will be where we lose less sodium. So sodium loss is greater. I'm sorry, we lose more sodium than we do water. So think about someone with renal insufficiency and inadequate aldosterone secretion. So the whole renin, angiotensin, aldosterone system and reabsorption of sodium is awry because of renal issues. So in that case, they're retaining water and losing sodium, which is a very rare instance because you know sodium and water like to go together. They go everywhere together, even to the bathroom together. So hypotonic dehydration is something that hopefully you don't see too often. And then isotonic dehydration. Isotonic means balanced. So that means sodium and water are both being lost from the body. And in this case, think something like diarrhea or vomiting, where they're both being lost at the same rate. And then it goes on to tell you what kind of conditions and corresponding symptoms might occur with different types of dehydration. We're not going to focus on that right now. We are going to start getting into IV fluids. And let's remember that tonicity, osmolality. Osmolality is probably familiar to you, or it should be. Hint, hint, you need to review if it's not. From patho, we often use them interchangeably, but actually osmolality is used to talk about body fluid, whereas tonicity is used to talk about IV solutions, where isotonic, hypotonic, hypertonic. So, you know, we talk about different tonicity in IV fluids that way. So as we come down, it gives a little bit of a definition about what isotonic means, that the osmotic pressure inside and outside the blood cell are the same, equal, isotonic, equal. Hypo means that the solution outside the cell has lower osmotic pressure than inside the cell. Think about the example I gave earlier of the fetus inside the amniotic sac. That's an isotonic situation. And I said if it was hypotonic, that would not be good. If it was hypertonic, that would not be good. And then hypertonic means the solution outside the blood cell itself has higher osmotic pressure than inside the cell. And where do things like to go? Think about water. Water likes to go to the path of least resistance. If there's a lot of resistance, then things are not going to shift towards resistance. They're going to shift towards least resistance. And osmotic pressure is resistance. So if you kind of remember it that way, you'll realize where things are going. All right, so there's a little picture to kind of demonstrate hyper, iso, and hypotonic situations with the red blood cells. It goes into acid-base balance here. We're not covering that just yet as our concept. We're still working on fluid and electrolyte balance. All right, fancy word coming up right here, crystalloids. You'll only hear it in school. You won't hear it much outside of the academic environment because in the hospital we call them IV fluids. But crystalloids are basically fluids that we give by IV injection that supply water and sodium to maintain a certain osmotic gradient. So we might need to manipulate that osmotic gradient that because it's not isotonic, we will have to manipulate it to get it isotonic. And that means we'll have to give different types of solutions. Crystalloid solutions are fluids and electrolytes that are normally found in the body. So that's how we're able to manipulate that gradient, is because we're giving something that the body already has, but it's out of balance. So we're trying to correct the balance. And then we have to, at the same time, work to correct whatever the cause is of the imbalance. But for starters, we correct the balance, and then along with that, correct whatever caused the imbalance. So I want you to think about something. If these are things that we normally have in our body, do you suppose that anyone's going to have an allergy to these things? No, they won't. They're not going to be allergic to normal saline or sodium or potassium. These are things that are normally found within the body. So that's one thing you can cross off your list for having to learn is allergies for any of these things that we're going to talk about. So I said fancy word is crystalloid. The other part of helping to maintain fluid and volume in the body would be something called a colloid. We're not covering colloids right now. Colloids have protein in them. Colloids are, an example would be albumin. Colloid would be red blood cells. If we give packed red blood cells to a patient, a blood transfusion, or plasma, fresh frozen plasma we might give to a patient. Those things all help to bring up volume and replace or correct something that's causing an imbalance. But those are called colloids. We are focusing on crystalloids. Now, crystalloids, I didn't highlight the whole sentence, but right there, are distributed faster into the interstitial and intracellular compartments than colloids. And that's why a lot of times crystalloids are better for treating dehydration than giving something that's just going to expand plasma volume. So why do we give crystalloids? What are the indications? Well, the most commonly used indication, ding, 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 most common use, right there is something you should highlight. The most common reason to give crystalloid solutions is to have a maintenance fluid. If you have a patient who is febrile and they are perspiring because of their temperature increase, we're going to want to compensate for insensible fluid losses. And so we will have them on maybe a slow rate at 70 mLs per hour perhaps to keep their body from going into a hyper or hypotonic state due to whatever is going on with them. So we use maintenance fluids. They compensate for insensible fluid losses. We might have to replace fluids. Maybe they had surgery and had fluid loss through surgery. Maybe they've had a bad virus, fluid and electrolyte loss through vomiting and diarrhea. And then we want to manage certain types of electrolyte imbalances. We also use crystalloids to promote urinary flow. When we talk about diuretics and getting them to help work, there's a diuretic that we use, a certain class, to help promote. It expands the vascular structure and helps to promote urinary flow. Well, in order to get, if the patient's not taking enough in orally to really get a good amount of urine coming through the kidneys, then we give it IV. Let's see. So what contraindications would there be to using IV fluids? Well, a known drug allergy. No one's going to be allergic to these. Hypervolemia. Someone has too much fluid and their heart and lungs are overloaded and overwhelmed. Yeah, we're going to have to be very, very, very careful and selective about using colloids crystalloids and how we use them. Under adverse effects, crystalloids are a very safe and effective means of replacing needed fluid. However, there can be some effects that are really not wanted. One would be fluid volume overload. But the other thing is they don't stay within the vessels. The liquids are going to leak out of the plasma into the tissues and the cells. That's what water does. It goes to the path of least resistance. Think about where the least amount of osmotic pressure is, that's where it's going to go. So that's why we have to put somebody on maintenance fluids. We have to maintain that fluid volume with crystalloids going into their body. They don't just get those fluids for an hour and then nothing else. It's not like our drugs that have a half-life and a time for elimination. These fluids need to be going constantly around the clock all the time because of the fact that they will move out of the plasma and into the tissues. Oh, see this last sentence. As a result, prolonged infusions can cause fluid overload. So that would be one of your adverse effects. So we have to be careful and measure I&O on our patients and their weight to make sure that they really are achieving fluid balance. So what kind of interactions might we have with crystalloids? Actually, not many, if any. Interactions with other drugs and such with crystalloid solutions are very rare because this is something that is identical or very similar to our normal physiologic substances that are found within our body. Now, the dose, how we dose crystalloids is in mLs, milliliters per hour, or it may be ordered as a volume of a liter over 8 hours, in which you have to do the math and figure out, I have a liter of fluid, how many mLs per hour do I have to run the fluid at in order to achieve getting this whole liter in 8 hours. So they're usually ordered along those lines. The most common crystalloid solutions that you will encounter are normal saline and lactated Ringer's solution. Normal saline is also a 0.9% sodium chloride. It's isotonic. It is the same percentage of sodium and fluid that we would find in our circulating vascular space, in extracellular space. I think I said that right. Sodium chloride is discussed briefly in the section on electrolytes a little bit further down when we talk about using sodium chloride as an agent to raise sodium. Right now we're going to look at it as a crystalloid. So sodium chloride, NaCl, normal saline. It's only normal saline if it's 0.9%. That's the only time it's normal saline. Don't ever call 0.45% normal saline because that's half normal saline. Only 0.9% is normal saline. So make sure you're using the right lingo. Sodium chloride comes in different concentrations. The most common is the 0.9%. That's the one that's physiologically normal to the concentration. It's sodium chloride in our body. Isotonic. That's why we use the word normal saline, abbreviated as NS. So the concentrations that we have are either hypotonic or hypertonic, which means they're either higher in concentration of sodium chloride in your infusion or lower. So they're either going to be higher than the 0.9% or they're going to be lower than the 0.9%. So hypotonic, less, hypo is less, lower, is 0.45. That's less than 0.9. So that is a hypotonic solution and it's half normal saline. 0.25% is also hypo. It's very hypotonic. It's quarter normal. I've never seen that one in an adult population. I'll just say. So if you pull a bag and it says 0.25%, you better make sure that's what you should be giving on your patient. So flipping from hypo, let's talk about hypertonic saline. This is a high alert solution. It should always be double checked with someone else that you are actually supposed to give hypertonic solution. So our normal is 0.9%. Hyper is more. And so 3% and 5% are higher. That's more, it's a greater number than 0.9%. So our hypertonic saline is 3% or 5%. That's how they come. They have different indications and different uses, and it all depends on how urgently we need to get fluid volume restored. Typically, if you're using a hypertonic solution, remember it's high alert, you will have a patient who is in a critical state and should be in a monitored ICU or possibly a step down unit, but should not usually be on just a regular medical or surgical unit. Remember that sodium chloride is an electrolyte that is present in our body's water. So there's no hypersensitivity reactions. Remember that. You don't have to remember allergies to saline or to sodium chloride. It's safe to administer at any stage of pregnancy. No pregnancy categories to know there. But if somebody has hypernatremia, they have a high level of sodium, we are not going to be giving them a lot of sodium chloride. If we need fluids, we may do lactated ringers. It has no sodium as far as I remember, or very little, or we might have to choose even a dextrose solution. Let's see. It goes on to talk about hypertonic saline. Here's where it talks about how it's high risk. It is considered high risk because deaths have occurred when it's infused improperly. It's very important. Never ever take it for granted when you're hanging a bag of IV fluids, crystalloids. Don't ever think it doesn't need that third check. It absolutely does. Because as you can see, it's never just normal saline. It could be you might think you pulled 0.9% and you actually have a 3%. You can cause death in a patient by hanging the wrong one. If we correct the sodium too rapidly, the hypertonic saline can lead to something called osmotic demyelination syndrome, which is potentially fatal. If we do a very low hypotonic saline, the 0.25%, remember that's the quarter normal saline that I said I've never seen used in an adult population. It can cause actually hemolysis of red blood cells. You do not want your red blood cells to be lysing and exploding and dying because they're the carriers of oxygen. And if we lose our red blood cells, there's a whole lot of bad things that are going to happen in the body. And we're talking about crystalloids, the liquid form of sodium chloride right now, and other IV solutions. But it makes a note here that you can get sodium chloride in a tablet form, and we'll talk about that in just a minute. The dose of sodium chloride, so how much your patient's going to get, it's going to depend on the clinical situation. And it can change throughout the patient's course of events. So generally speaking, the amount needed of normal saline, 0.9% NaCl, is whatever we need to increase intravascular or plasma volume. And we do it in by liters, by a milliliter. So 1 milliliter is 5,000 to 6,000 mLs of plasma volume. And then it goes on to talk about albumin that we're not covering right now. Table 29.3 looks at dosing guidelines for crystalloids and colloids. I am not going to ask you how much plasma volume is increased by a liter of normal saline. This is just something that you can look at to see how that is affected based on the different percentages there. This next section covers colloids, and those different products are dextran, which is iron, hetastarch, and albumin, and then it'll go into blood. We're going to come past that. We're not going into colloids right now. There's blood products. I'm coming down past the blood products. And we are now on page 470. And the topic here is physiology of electrolyte balance. So we've talked about fluid and normal saline or the use of saline, or its equivalent partner called Ringer's lactated or lactated Ringer's. It's basically isotonic. It's just used to maintain fluid volume. Now we're going to talk about those electrolytes that are going to move in and out of the cells based on osmotic pressure in that intravascular space. So would they go hand in hand when we talk about fluids? We're going to talk about electrolytes. So the primary electrolytes we're going to talk about are sodium, potassium, magnesium, and a little bit maybe with chloride and calcium in this case. But for us right now, we want to focus on sodium, potassium, magnesium for you to know. I can't remember if I put chloride, my apologies right now, on the objectives. If I did, we need to look at that one also. Now, you know, as a review, that electrolytes are very, very important in the body as part of nerve impulse transmission, muscle contraction, and regulation of water distribution, and so on. So, what's a major muscle in our body? Yeah, the heart. The heart's a muscle. That's the one I think of first. And if we are messing around with nerve impulse transmission and muscle contractions, and it affects the cardiac muscle, that can be a very serious thing. So that's why we need to learn about these. So sodium and chloride are the principal electrolytes extracellular. Potassium's your principal intracellular electrolytes. So the potassium's supposed to stay in the cell with only a little bit floating around in the blood. So when you draw someone's blood for labs and you get your labs back, that's the potassium, the majority of the potassium, 95 to 97% should be in the cell. So your potassium level out in the fluid, in the circulating vascular area where you drew the blood from, should only be about 3 to 5. 3.0 to 5, some places say 3 to 5.5, but basically that's all that we should have circulating. And when it's higher than that, that means there's not enough potassium inside the cells to do their job. When it's lower than that, that means there's too much potassium inside the cells and they're doing too irregular parts of their job. Then the same thing happens with sodium. So we need more sodium outside the cell floating around. So when you draw someone's sodium level, it should be high, right? Not high, but its normal level is going to be higher than what you have for potassium. And I want to be consistent with what they say in here for your sodium levels. Oh, we're on potassium. When we get down to sodium, we'll talk about that one. It's very important to remember that even small changes in that extracellular potassium level can lead to very serious unwanted neuromuscular and cardiovascular system issues. We get potassium from a variety of foods. Later on in this chapter, some very specific food sources are discussed. You need to know those because you need to be able to teach a patient what foods they should have to increase potassium and what foods they should avoid so that they don't get too much potassium. So a hypokalemia is when we don't have enough potassium. So you drew their blood, you see their labs, their potassium level is low. Where is the potassium? The potassium is in the cells instead of, there's too much. It's exceeding how much should be in the cells. So that's what that means, hypokalemia. And that's a serum potassium level less than 3.5. There's different things that can cause that and bring it on. There's even medications that can cause it. Beta blockers is one, and you're going to hear about those very soon. So you need to know symptoms of hypokalemia because we don't just rely on the lab work. Sometimes the lab work's not back. Sometimes the computers are down. And sometimes you're a home health nurse or a clinic nurse and you're seeing a patient who's having hypotension, lethargy, mental confusion, muscle weakness, and nausea. And you know that they're on a beta blocker or a diuretic that wastes potassium. This is a time to suspect hypokalemia. You don't want to see the late symptoms because those are the things that can lead to death. When someone has a very low potassium, we will have to give them potassium IV, which we're about to talk about here in just a minute. Hyperkalemia, so now we have excess serum potassium. That means all that potassium that's supposed to be in the cell, too much of it now is out floating around in the vascular space instead of staying in the cell where it belongs. So that's when we have a serum potassium level that comes out as 5.5 or higher. This results from maybe taking in too much potassium or the kidneys, the renal system is not excreting potassium the way it should. Maybe patients who have burns usually have this extracellular compartment. It's called third spacing, and the potassium is held on to that way, or rhabdomyolysis can lead to this as well. So you need to know the symptoms: generalized fatigue, weakness, paresthesias are tingling in the like the fingers, the hands, and the feet, or even tingling like on the face, in the cheeks, palpitations, heart palpitations, and paralysis. Um, so clinical manifestations, things we might be able to auscultate, listen to, or see on a telemetry or an EKG would be changes in the cardiac rhythm. You can actually precipitate ventricular fibrillation and cardiac arrest with a serum potassium level greater than 7. So if we're going to give potassium to a patient, what's the mechanism of action? Potassium works on muscle contraction and the transmission of nerve impulses, which we mentioned already. It also plays a role in enzymatic reactions, and it's an essential component in gastric secretion, renal function, tissue synthesis, and carbohydrate metabolism. So when you learn about DKA or hyper HHS, the one that goes with type 2 diabetes, that's similar to DKA, you find out about potassium and that they actually have hyperkalemia with that. And that's all related to carbohydrate metabolism. Why do we give potassium? Well, we give it to prevent potassium depletion or to correct potassium depletion. We can give it orally. With there are tablets. There are tablets that are enteric coated and that are not enteric coated. Both still cause a lot of GI upset. It's like a burn. Potassium burns. It's a salt, potassium salt. And you know how if you put salt on a wound, mucous membranes, or some kind of an open wound, it'll burn. Well, that's, you think about pouring salt inside. You open up the skin and get down in the tissue and pour salt in there, it's going to burn. And so, a lot of times when we're giving IV potassium, patients will complain of burning at their IV site, and you may even see phlebitis, the redness and the streaks, and we have to start a new IV. Sometimes we have to slow down the infusion of potassium so that the patient achieves comfort. It's much easier to give it through a central line. We avoid some of that when we do a central line. But thinking about oral potassium, the adverse effects are generally GI, and they have nausea, vomiting, sometimes diarrhea. But the more significant effects are it can actually cause a GI bleed or ulcers in the stomach. Parenteral administration, which is IV, does can produce pain at the injection site that I just mentioned. Generally, we just slow the infusion to try and help with that, or start a new IV, go to a new site. Something that is very important is that excessive administration of potassium salts can lead to hyperkalemia and toxic effects. So IV potassium should never be administered too rapidly. It should never, ever, ever, never be given IV push or as a bolus, because you can cause cardiac arrest. It's always diluted in fluid and given over usually at least an hour. It can go longer, which is when the patient has pain at the injection site. We alternate to where the infusion rate is slower, and it can take an hour and a half maybe for it to go in rather than an hour. And that's okay. What's not okay is for it to go faster. A patient should not receive more than 10 milliequivalents in an hour. That's the limit, unless they're being having cardiac monitoring in a critical care unit. Toxicity and management. So if the patient is hyperkalemic, if they get too much potassium, we will give dextrose and insulin solution that helps to move the potassium. We can give sodium bicarb because they will become acidotic, and then calcium gluconate or chloride can also be required. But one of the things we're going to talk about is the K-exolate, polystyrene sulfonate. Here we go, sodium polystyrene sulfonate, K-exolate. Can also be administered orally or rectally to help pull potassium out of the body. If necessary, we will have to do dialysis, hemodialysis, to get the extra potassium from the body. Oh, pardon me, I'm very sorry for coughing right in your ear. So what types of things could interact with potassium? Well, a patient taking a potassium sparing diuretic like spironolactone and taking an ACE inhibitor can actually become hyperkalemic, because both of these things, the ACE inhibitors help to preserve potassium in the body, and the potassium sparing diuretics do the same thing. And so we want to be very careful about those two things being administered together. What kind of doses are we talking about with potassium or with fluids and electrolytes? It's going to be very patient specific and situation specific. It depends on how much loss the patient has of fluid or electrolytes, the cause of the losses, how efficacious the patient's own physiologic systems are, what other underlying illnesses they may have, what other types of drugs they may be taking that can complicate everything. And then we from there can select oral or IV parenteral replacement formulations. So there's no way for me to tell you that this is the usual dose of something. The most common things I can tell you is oral, because let's start over. Because of the GI effects of potassium when someone takes an oral formulation, the way the orals come is usually in 10 or 20 milliequivalents, usually not higher, because of the effect on the gastric mucosa. And so if a patient requires more than 20 milliequivalents orally, we need to separate those doses and make sure they're eating so that we can protect their stomach. Now, we may also give 10 to 20 parenterally, IV. And but again, always remember the rule of thumb: you will never give more than 10 milliequivalents in an hour IV, unless you're in a critical care unit and they're being monitored for cardiac changes. So here we're talking about potassium. Again, they're used to prevent or treat potassium depletion. The dosage is going to be expressed in milliequivalents always. It's not in milligrams. It's always in MEQs, milliequivalents. And every patient's going to require a different dose, and it may change from day to day depending on the situation. It's a pregnancy category A drug because this is something that is normally found within our body. So for IV, onset of action, immediate. Peak plasma concentration is rapid. Now, elimination and duration are going to be variable based on patient situation. I touched on just a minute ago, and now we'll expand on K-exolate. The name is sodium polystyrene sulfonate. It's a potassium exchange resin. I find it much easier to say K-exolate. But it's a cation exchange resin, and we use it to treat hyperkalemia. It's a suspension, a liquid suspension, and if I remember right, it's brown, and it looks like very weak hot chocolate, but it does not taste like very weak hot chocolate, which is why we usually give it through, here we go, orally, via a nasogastric tube, or we give it as an enema. It's a rare patient that can actually tolerate drinking enough of the K-exolate to achieve what we need. So we usually have to drop an NG tube and give it to them that way. But it can also be given as a retention enema for patients who are unable to have an NG tube or swallow. It works in the intestine, and that's where potassium ions are exchanged for sodium ions in the resin. And what ends up happening is the patient has diarrhea, and that's where we lose the potassium, is through the diarrhea. A lot of fluid loss happens also that way. So because it works in that part of the body, in the intestines, the biggest thing you need to know is that you cannot give K-exolate to a patient who does not have normal bowel function, because it's going to require that they have normal bowel function. Otherwise, you can cause a necrosis in the bowel, actually, and possible death in the patient. So how does a nurse know if her patient has bowel function? Well, number one, are they having bowel movements? Number two, you use your stethoscope and you listen for the presence of normoactive bowel sounds or hyperactive. That indicates bowel function. And you can palpate as well and feel to make sure there's no distension, there's no bloating, there's no hard, firm problems, that it's soft and non tender. So if a patient's constipated, we do not give Kxalate. If they have no bowel sounds, we do not give Kxalate, etc., etc. So that is the biggest primary role of the nurse prior to giving the Kxalate, is to establish that the patient does have bowel function. All right, let's see. Now we're going to talk about sodium, and it's the counterpart of potassium. I already talked about them being the principal cations inside and outside the cells. The normal concentration of sodium outside the cells is 135 to 145 milliequivalent. So that's a lot higher than the potassium. But if you think about how much would then be in the cells, they're almost equal. Not quite, but almost, in the way that they are opposite. Hyponatremia, loss or deficiency of sodium, is when you have a serum sodium level less than 135 milliequivalents. That means they've lost too much sodium. And you will see lethargy, hypotension, possibly stomach cramps, so some GI problems, vomiting, diarrhea, and seizures. It does affect, if you're hyponatremic, I want you to think about how a plum, I think it's a plum, becomes a raisin. It dries out, and that raisin is just a shriveled or dried up, like a prune or a date or a raisin. They get all dried up and shriveled where they originally started as a nice plump fruit. Well, if you do that to your brain, you're going to have some consequences. So hyponatremia, severe hyponatremia, can result in seizures because of the effect on the these cerebral effects. There's different types of hyponatremia. This isn't the patho course. I'm not going to ask you about those. I want you to know about giving sodium. Hypernatremia is when we have too much sodium. And now we come down to, why would we give sodium? It's given to prevent sodium depletion or to treat sodium depletion, just like the potassium. Same indications, but it's sodium instead of potassium. And sodium chloride is the primary salt we use for this purpose. So if someone has mild hyponatremia, we might give them some sodium chloride tablets and put them on a fluid restriction. Why a fluid restriction? Because the more fluid you take, the more you pee. And the more you pee, the more urine you lose. And what goes with fluids? Sodium. Sodium and water love each other. They love each other so much they even go to the bathroom together. So remember, when you're losing a lot of urine, sodium's usually going with it. Except in the case of certain things like diabetes insipidus. And possibly SIADH. You'll learn more about those later. So we have talked about using sodium chloride IV, the parenteral formulation. And it talks here about the hypertonic saline, so that would be like our 3% or 5% sodium chloride. Sometimes can be used to correct severe hyponatremia. You know, if we need to correct it really fast, we can give that. And if you think about what I just described happens to the brain with severe hyponatremia, yeah, if my brain's drying out and becoming a raisin, I want the 3% normal I'm sorry, there it is. 3% sodium chloride going IV into my body to get my brain back up nice, juicy, and plump. And that'll do it. But if I get too much of that, or I didn't need it in the first place, my brain's going to explode because it's going to have too much. It's going to swell. So it's kind of a really tricky balance. That's why it's considered a high-risk drug. You don't want to give it too rapidly. It can cause central pontine myelin olysis. Myelin, think about nerves. Olysis, things are going to die. Or it's also known osmotic demyelination syndrome. It can cause irreversible brainstem damage. So, you think you might want to use a pump, an IV pump to control the infusion of a hypertonic saline? You bet. You do not want to come in that room and find out that your liter that was supposed to go over 6 hours or 12 hours has gone in 2 hours, because now the patient may have suffered irreversible brainstem damage. So very, very important nursing consideration when giving this high alert, high risk drug, hypertonic saline, is to make sure it's on a controlled infusion device, an IV pump. The contraindications to using sodium replacement would be hypernatremia or a known allergy, which doesn't exist. Patients can get upset stomach, nausea, vomiting, and cramps from the oral administration of sodium chloride. That's why sometimes just giving them an IV, sometimes they'll come into the clinic or an outpatient setting that maybe has the ability to just do an IV infusion of, give them a liter of fluids, normal saline, and they're on their way and they're fine for a mild dehydration. You know, if you watch football, like I do, I watch my college football, they have the tent on the sidelines, and sometimes, depending on where they're playing and what the conditions, the weather, temperature, things like that, the altitude, some of these football players can get very, very dehydrated during the game, and they cramp up. They get really bad cramps, they get nauseated, they get headaches, and they'll take them into the tent and give them an infusion, an IV, a quick liter or half a liter maybe of normal saline, and it just gets them both fluid balance back up, and then they go back out and play. Then use that to kind of think about with fluid and electrolytes. Okay, the dosages are going to depend on the patient situation, just like with our potassium. So let's see, drug profile for sodium chloride. It is primarily used as a replacement electrolyte to prevent or treat sodium loss. We also use it because it's isotonic. It's used as a diluent for the infusion of certain drugs that are compatible with sodium chloride. So if we need to give an IV antibiotic, or we need to give IV some ondansetron for nausea and vomiting, we can't. Some of these drugs we need it to go over 30 minutes or 45 minutes or 2 hours. Well, you can't sit next to a patient with a syringe and push a drug over 2 hours. Not possible. So we put it in maybe 100 milliliters of normal saline because it's compatible with it, and we squirt it into that bag and we dilute it, and then we can hang it on an infusion pump or control the rate, and it can run over an hour or 2 hours. And that's when it's used as a diluent. It may also be used to dilute a powdered form of medication to become a liquid form that we can inject. Protonix is one of those drugs that comes as a powder, and we inject 10 mLs of normal saline into that vial and then withdraw the 10 mLs. It becomes liquid. It all diffuses and no more powder, and you draw it up into a 10 ml syringe, and then you can administer it IV push from there. So the pharmacokinetics, if we give it IV, onset of action is immediate, peak plasma concentration is rapid, the rest is either unknown or variable. We've got conivaptan. I don't know how to say it, and we aren't talking about it, so we will pass that. And now we're on to the nursing process, page 473 in your book. And this is where you'll find the information about actually giving these drugs to your patient. Assessment is the first thing. And then as we come down into like about the second, I think it's the second, third, maybe paragraph starts with the word potassium. It will tell you specifically about your potassium. And again, it reiterates what the normal ranges are, what is hypokalemia, symptoms, what is hyper, and those symptoms, and comes on down into venous access. Okay. Venous access means having an IV, either a peripheral IV or a central line, and it's a very important issue when we have parenteral potassium supplementation, which means IV potassium drug administration, because the vein can become irritated, and so we have to have be on the lookout for that. We need to assess before you administer the potassium or start the infusion. Make sure that the IV site is good. How long has it been there? Is it 5 days old? Would it really be better to start a new IV? What's the condition of the site? Does it flush easily or not? So you know you need to assess the condition of your IV route and site. It goes on there to about IV site selection. You're not held to knowing that. You need to know, number 3, why you're giving potassium or other electrolytes. Number 4, you will have to calculate your rate and set your pump for the infusion. Remember, we're going to put potassium on a pump. Know how long this should last. How long should the patient have to get potassium? And then anything that might be a restriction in a patient. It's talking about IV access right here, about post-mastectomy, lymph node dissection. You do not need to know all of that. I just want you to know that it can irritate the veins. You want to assess the site to make sure there aren't pre-existing problems that infusion of potassium is just going to make worse. And that you have to regulate the infusion very carefully. Coming on down, now we have our sodium, and it's going to, remember to read this. That's why I'm pointing it out to you, because it's going to reiterate some of the patho. It's going to bring in signs and symptoms of hyponatremia, hypernatremia, things that you need to do when you're administering this drug. So hypernatremia, when somebody has a sodium level above 145, 135, I'm sorry. Let's see their numbers. Yeah, actually above 145. But when they're hypernatremic, here are some of the things you might see, and you need to be watching your patient very carefully. Remember, too much sodium is not good for the brain, just like too little sodium isn't good for the brain or the rest of the body. But I worry about that brain. I worry about the heart with potassium and the brain with sodium. So you might see red flushed skin, dry, sticky mucous membranes, increased thirst. Why? Because the body says, I got to get rid of sodium. So if I get fluid out of the body, sodium will go with it. So I'm going to drink a whole lot of water so that I make a lot of urine and urinate large volumes, because I know that sodium and water go together everywhere. They're such good friends, they even go to the bathroom together. So if I'm hypernatremic, I'm going to make this patient be thirsty. Does that make sense? I hope so. You may see temperature elevation because you're starting to have problems inside the regulatory mechanisms of the brain. Edema. Well, the body can only hold so much water. Remember, the water's going with the sodium. The sodium doesn't want to leave, so the water's not going to leave. It's going to stay. That's what's making the brain swell. Well, it'll make the vascular spaces swell also, and you'll see edema all over, generalized edema from head to toe, and it's called anasarca. You'll see it. It's all over. It's in the face, in the neck, in the shoulders, in the chest, in the arms, the legs, everywhere. They can have hypertension because there's so much pressure now. And they may have decreased or absent urination. Anuria would be absent urination. And in that case, you know you've got to start treating this patient. This goes on to talk about now albumin and colloids. We can go whoosh, whoosh, cross that out. We don't need that. Or blood products. And then it has, in summary, it'll just wrap everything up there for you. All right, implementation, monitoring of your patient, especially the things you'll see for serum electrolyte levels, potassium, cardiac monitoring, sodium, neurologic monitoring. Frequently monitor the site, IV site, when you're infusing potassium. For thrombophlebitis, no blood return, things like that. You need to monitor for volume overload when you're giving IV fluids. Here it is again. Check, how many times can they say? Check the IV site and then tubing, IV bag, or fluids, as well as expiration dates. Your fluids should be crystal clear. They're called crystalloids, crystal clear IV fluids. Keep in mind your age implications for pediatric and adult patients. Know the osmolality and concentrations. Understand osmotic changes. Isotonic solutions such as 9% sodium chloride. You need to know what a hypertonic solution is. What's a hypotonic solution? What's it going to do to the patient if I administer this? What's the goal of giving a hypertonic solution? What's the goal of a hypotonic solution? Here are your foods for potassium. Here, if you need to tell, a list of foods containing potassium are all right here. There we go, right there. So that you can educate your patient on minimizing potassium intake or maximizing potassium intake. You need to be aware of that. Goes into the oral formulations, and one of the things about oral forms, they need to be taken with food to minimize gastric distress or irritation. A lot of times they come as a powder or effervescent, and you need to mix it with the appropriate amount of fluid. It'll say on the packaging. They do have enteric or sustained release forms, but let me tell you, those still cause GI problems. It's not a ticket to no GI issues. Here's our sodium polystyrene sulfonate right here that you need to know. Under no circumstances do you give this to a patient who has absence of bowel sounds, known constipation, or any other irregularity or abnormality within the intestinal tract. And it says right here, never give it with sorbitol, because the connection of these two drugs with potentially fatal colonic intestinal necrosis can occur. Okay. It talks about the enema too for KXLate. We want the patient to retain it as long as possible. And oftentimes they will have a cleansing enema afterwards, because if that stays in, so let's say that we do the enema, patient has some diarrhea, their potassium corrects. Well, there's still some residual in the intestinal tract. And so that needs to be cleansed out. Otherwise, now they're going to become hypokalemic. The concern and caution with potassium chloride is always to avoid overdosage. IV forms must always be given in a diluted form. There is no use or place for undiluted potassium to be given IV push or bolus, ever. You need to have adequate urine output in order to excrete the potassium and maintain some homeostasis. It says it again here, there is no place for IV push or IV bolus potassium replacement. So I think that can't say that enough. Now, if we come down here to sodium, here's your dietary information for sodium. Items high in sodium: ketchup, mustard, cured meats, cheeses. Almost all dairy products are high in sodium. Potato chips, peanut butter, popcorn, and table salt. Who knew? So if you need to do patient education on sodium choices, that's where you can start. Canned soup, high amounts of sodium in canned soup. Goes on to talk about your hypotonic solutions, hypernatremia, another, again, overview of that. And you don't need to read about the colloids. And then you have a case study. Patient-centered care with teaching, you'll want to look at that. Don't forget about your key points. Review the key points of every chapter. I recommend you look at those key points before you read the chapter, because they will help parts of the chapter jump out at you and know that you're reading something important. And then you can test yourself on exam review questions. It appears I have highlighted number 2. What is number 2? When preparing an IV solution that contains potassium, the nurse knows that a contraindication to the potassium infusion would be what? So what would be a reason not to give potassium IV? Diarrhea? Most patients lose potassium when they have diarrhea, so I don't think so. Serum sodium level of 145, well, that has nothing to do with potassium. A serum potassium level of 5.6, that's kind of high, and I'm going to give potassium, so the thing is I'm going to make that higher. Or dehydration. It's C. You will not give IV solutions containing potassium if you have a patient with a potassium level of 5.6. You need to hold it, call the provider, and have a discussion. All right, I've reached the hour mark. I'm going to shut this down. Say thank you for listening. I hope this has been helpful. Study hard, and God bless you.